Good afternoon, everyone, and thank you for attending. We wanted to do this program because we felt it was very important with the nursing home regulations being released and some of it being on ownership issues. And that was something that we had made some extensive recommendations about, and we would like to make sure that everyone is educated about what it means when a license transfers, and we've seen a lot of transfer of licenses from nonprofits to for-profits and so on. So we really wanted to provide this update for people so that they understand we all understand what's been happening here with changes in ownership. I would like to first, we have some wonderful speakers today, and I just want to thank them for being here because it's just amazing. The work that they've done and that they will share with us today. First, I'm going to introduce David Hoffman. David is here as an expert, but he's also going to be moderating the program for us. David has been, right now, he has a company called David Hoffman and Associates. He started in 2005, which is a consulting firm that works nationally to help some of the nation's largest healthcare providers adhere to regulatory requirements designed to ensure patient safety through legal and clinical compliance. So he is an authority on the practice of health law and corporate compliance. He brings decades of experience to litigating high-profile matters. I met David back in 1989 when he was general counsel for the Department of Aging in Pennsylvania. And so I've known him for a long time. We worked together back in the 90s when David went to the U.S. Attorney's Office and did some groundbreaking work on prosecuting long-term care facilities that weren't doing the right thing for their residents. And we worked on a case that David ended up taking on and put a for-profit company out of business in New Jersey and Pennsylvania. And that was, as far as I'm concerned, very groundbreaking. And I know that it set the stage for a lot of new ways to approach cases, including through the False Claims Act. And so he's been working in the private sector as well as teaching in law school at Drexel University to try to help, of course, prepare incoming professionals to do the work that he does now, and or to at least be interested in it. So he's also gotten awards for his work through the U.S. Department of Executive Office for United States Attorneys, 2 Directors Awards, and he's also gotten a DHS Inspector General's Integrity Award. And let me tell you, David has integrity. So I'm going to turn it over to David, who will help moderate the session and introduce our speakers. Thank you, David.
Thanks, Diane, and welcome everyone. First, thanks to you and Kathy for creating this webinar on this very important topic. We know that private equity has invested in all types of businesses and that there are success stories and failures. But from my perspective, healthcare is different. It's different because lives are at stake. And today we will be focusing on the nursing home industry that is caring for the most vulnerable population out there. And we've seen just horrific outcomes during COVID. But it was even before COVID, there were problems. There were plenty of things brewing, especially around ownership, who is in this business. So we are very fortunate today to have 2 experts assist us in achieving our goals of educate, discuss, and perhaps come up with some possible solutions to reduce the risk to this vulnerable population. And I'll start by introducing Dr. Atul Gupta, who is an assistant professor at the Wharton School at the University of Pennsylvania. Dr. Gupta is also a senior fellow at the Leonard Davis Institute of Health Economics. He received his MS and PhD degrees from Stanford University. He also has an MBA from the Indian Institute of Management. Dr. Gupta co-authored an eye-opening and deeply troubling article about a year ago, I guess it is already, Dr. Gupta, titled, Does Private Equity Investment in Healthcare Benefit Patients? Evidence from Nursing Homes. He will be explaining private equity's impact on healthcare with a special focus on the nursing home industry. We are then joined by Ernest Tosh, who is an attorney with a national practice focused on nursing home abuse and neglect. Mr. Tosh is a frequent lecturer on forensic accounting and nursing home litigation and has testified on multiple occasions as an expert in this area, including testifying before Congress. And he survived that experience, which was good to know. Before starting his firm, Mr. Tosh worked for the Tarrant County District Attorney's Office, which I believe is located in Fort Worth, Texas. Mr. Tosh will be providing an analysis of nursing home finances and related party transactions and their impact on nursing home staffing and the absolute need for transparency of nursing home ownership. And so with that, I'll turn it over to Dr. Gupta.
Thanks, David, and thanks to the organizers for putting together this wonderful session. And I hope that we can all learn a lot about private equity and the things that we should think about when private equity invests in healthcare. I will share my screen now. Can you guys see this? Okay.
Yes.
Perfect. So as David said, I'm going to talk about some of my learnings from my research on the effects of private equity for patients, and then also on costs when they invest in nursing homes. And this draws on research that I worked on jointly with my co-authors, Sabrina Howell and Abhinav Gupta, who are at NYU Stern, and then Constantine Yanellis, who's at Chicago Booth. Ernie was also kind enough to share some of his content with me, and so some of that is also reflected in here. So I'll begin. So my plan is, and I think I have 30 minutes to go through this. So I'll spend some time giving the audience some background on what private equity is, the private equity model, and I believe Ernie will also speak a little bit to this. So Ernie, please feel free to cover the things that I somehow omit, and then I'll talk about the point that actually David raised, which is that healthcare is slightly different from other industries. So I'll talk about it a little bit more in abstract terms about what makes healthcare different and why we may worry about the presence of private equity or the private equity model in healthcare. I'll then switch gears and talk about results from my own work after giving a little bit of an overview of what other people have found when they've looked at the effects of private equity in healthcare. And then at the end, hopefully I'll have maybe 5 minutes to talk about just what I think are my takeaways or lessons from my very brief work on this over the past couple of years. So there's this very important and long-standing question in healthcare, in health economics. I'm an economist, so my sort of lens of looking at this whole question is from as an economist. And that question is, does ownership type matter? Does different types of owners produce different types of outcomes? This is a very long-standing question going back to some seminal work by Ken Arrow, who wrote in 1963, all the way back 60 years ago, or nearly 60 years ago at this point, that non-profit firms are more altruistic and quality focused. And the downside is that they might be more inefficient, but in a sector like healthcare, we may be willing to accept that trade-off. And since then, economists have been thinking about the trade-offs of having for-profit and non-profit firms coexist in a sector like healthcare. In terms of the evidence on whether this matters, unfortunately, the evidence is actually quite inconclusive overall, at least in the case of hospitals. People have found that ownership doesn't seem to matter in terms of outcomes. In some studies, they found that they do seem to matter. But when you think about nursing homes, the evidence actually is a little bit more consistent. People across the board have found that non-profit nursing homes seem to do better than for-profit nursing homes. Now, the differences are not very dramatic, but the differences do seem to be significant. And they do suggest that nursing homes that are for profit, they tend to invest less in care for their patients, particularly in terms of nurse staffing, which is the biggest factor, single biggest factor in the input of nursing home production. Now, private equity, and I'll talk more about private equity on the next slides, but private equity is obviously an important new form, not new at this point, it's been around for about 3 decades, but it's an important form of organizing a firm. And there's been a lot of work theoretically that's been done on the effects that you can expect when private equity firms invest in a particular industry. And if you look at the results, at least from the finance literature, the results are actually broadly positive. So when they've looked at the effects of private equity ownership in a variety of industries, ranging from logistics, retail, restaurants, um, consumer goods, they've actually found that private equity ownership improves profitability, improves productivity in terms of sales, per either per revenue per consumer or revenue per employee. In some cases, they've also found that product quality increases, and private equity firms are good at increasing access to credit for their target firms. At the same time, this literature has also noted that private equity firms do increase the debt burden for the companies that they invest in, and there seems to be some bad effects for their employees. It increases employee churn, and we'll come back to this issue. So why is this important? Well, it's important because private equity seems to be investing a lot in healthcare. Healthcare now seems to be the new frontier for private equity firms. This chart is showing the trends in private equity ownership in healthcare over the last 2 decades, from 2000 onward. The red line tells the number of deals, and you can see it's monotonically increasing. And the bars give the total value in dollar terms, which you can see on the left side. And you can see that that's also more or less monotonically increasing, except for this big blip in 2006-07. And we know what that was. That was basically this one large deal where Bain Capital bought Hospital Corporation of America, HCA. So it's really an outlier, which tends to inflate deal value in 2006-07, just prior to the financial crisis. But since then, again, it's been monotonically increasing. And I think Ernie has some updated numbers on this, where he shows that even for 2020, even in a pandemic year, private equity firms have continued to invest. So what is private equity? So private equity is this idea that there's a set, there's a firm, there's an investment firm basically, and these people are called general partners. They put together a fund where they raise money from wealthy investors. So these investors could be corporations. For example, a lot of pension management companies invest in private equity funds, sovereign wealth funds, wealthy individuals. So these people give their money to these private equity general partners. The general partners make a commitment that they're going to invest this money in a variety of different forms. Sometimes it could be generic, sometimes it could be focused on a particular sector. But in all cases, sort of the general deal is that they will invest this money and they will generate a certain minimum amount of returns, and they will return this money along with the returns to these investors, typically in 8 to 10 years. So that's usually how the deal works. What they do with this money once they get this money is they combine this equity or this capital with a lot of debt. So they raise a lot of debt from debt markets, and then they combine this debt and equity, and they use this money to buy controlling stakes in their target firms. So one distinguishing characteristic of private equity is that they always buy controlling stakes in their target firms so that they can actually affect changes in the management at these firms. Now, another distinguishing characteristic is that the debt that they raise is placed on the target firm's balance sheet. This is highly unique. So the private equity firm itself does not take debt on its own balance sheet. If a private equity firm buys a nursing home company, for example, the debt is placed on the nursing home company's balance sheet, which means that that company is responsible for servicing the debt. And if that leads to cash flow issues, that's a problem that company will have to deal with. And how does the private equity firm make money? Well, they receive annual management fees from the fund. This is usually small. It's like 0.5 or less than 0.5% of the fund value. They receive some monitoring fees from the target firms in which they invest. And then the biggest part of their income actually comes from a share of the profits when they sell their stake in the private equity firm, in the target firm. And they generally get about 20%, which is called their carry interest. How do they increase? So this whole there's a little bit of financial engineering involved, but broadly speaking, their goal is to increase the value of the target firm in which they invest. And if you look at the literature, it talks about a variety of ways that they do this. They do financial engineering. They make changes to the management structure at the target firms. They sharpen the incentives for the leadership at the target firm to increase the value of the firm. And then they do operations engineering, which is to say that they actually get involved in changing day-to-day operations at the target firms. And this is where things like changes to staffing might come in. They have to exit in 5 to 7 years because remember, they have to return the money to investors within 10 years. And it takes them some time to identify targets. So they typically exit in 5 to 7 years. And they only get their carried interest if they actually exit. So they have to exit for their payoff. Now, in abstract terms, this is all fine. If they're investing in an industry which can be classified as a well-functioning market, then actually well-functioning markets will align the incentives of the PE firm with those of the customers or consumers in that market. And we'll come back when I talk about healthcare. We'll talk about how healthcare, what is a well-functioning market, and how healthcare deviates from a well-functioning market. So you might be wondering that even from the description that I've given, it's not exactly clear how private equity ownership is different from traditional for-profits. I mean, aren't for-profits also interested in profit maximization? Yes, they are. But I think that private equity firms differ in some specific ways. One is, which I already alluded to, is this financial engineering aspect, which is that the target firm is loaded with debt, and an ordinary for-profit doesn't necessarily do this when they buy stakes in a firm that they're interested in. Now, theoretically, this can have ambiguous effects because the corporate finance literature does mention that there could be some upside to this. But one thing that is very clear is that if you suddenly are now having to service a lot of debt, it is going to sharply affect your cash flow because you need to set aside some amount of cash to just make interest payments. The other thing that distinguishes them from regular for-profit ownership is their short-term horizon, right? They have to sell in 5 to 7 years, which means that they're focused on actions that can deliver immediate payoffs. And this would, and actually maybe I can combine this with the third point, which is the sale focus. They only make money if they sell their interest in this firm. And this is actually a point where they really distinguish themselves from traditional for-profits, right? If you think about family-owned for-profits, they don't necessarily think about just maximizing value in the short term and then selling their stake. They might actually think of retaining control indefinitely in a firm and sort of, therefore they might think about actions which strengthen the position of the firm for the long term. Because of this sale focus, private equity firms are also not averse to selling off assets, of hard assets of the firms that they invest in. This idea that they can break up the firm into different parts, and then the assets that can be monetized, they actually sell them off early, which does wonders for their returns on the deal or returns on equity. In the extreme, we have seen cases where private equity firms can still make money on an investment, even if the target firm eventually goes bankrupt. And you can see this because a lot of the value of these target firms is often locked in the real estate and land holdings. And if you actually separate that and sell that early in the ownership, then that's a huge positive on cash flow. And then later on, even if the firm goes under, there's not a lot of value in the day-to-day operations of the firm itself. I'll skip this part just in the interest of time, and then let me talk about this. This is, I think, important. So. I alluded to sort of in more abstract terms, the things that private equity firms do, and this is not limited to healthcare. This is a common playbook that they implement regardless of which industry they go into. One is this idea of sale leasebacks. So specifically, imagine a hospital that they buy, the real estate and the land, the real estate and the building and so on would may be very valuable. They'll separate that into a different company, sell that, oftentimes to a related company, a company that's owned by another company that's owned by the private equity firm. And then the hospital or nursing home has to lease back their own land, or formerly their own land, and their building from this third party. So while earlier, they may have had no mortgage payments, or even if they had mortgage payments, now they actually have to make lease payments, which oftentimes might be much higher. Another thing that private equity firms do sometimes is this idea of dividend recapitalization. And there was a flurry of these actually in 2018 and 2019 when the stock market went up. The idea here is that when interest rates are pretty low, you can actually get cheap debt. And so they make the target firm raise cheap debt, but then the proceeds of that debt are actually partially used to pay dividends to the private equity firm that is the owner of the firm. And this is actually very useful for the private equity firm, again, to make return on equity in its investment. I've already mentioned management fees, where the target firm has to pay the private equity owner an annual fees for its monitoring services. Presumably, this is because the private equity firm brings in expertise on better management, expertise on how to make better strategy on growth, and so on and so forth. Another way that private equity firms increase their revenue is they may have ownership in multiple firms, and some of those firms could potentially be relevant to a hospital or a nursing home. They may provide management services, they may provide some other types of consulting services. And so they nudge the hospital or nursing home to hire these other subsidiaries of the private equity firm as suppliers in some shape or form. And so this increases revenue for the private equity firm indirectly. And finally, they also do roll-ups, which legitimately increases value of the target firm. The idea here is that they increase the scale of the target firm by acquiring some of its competitors, either in the same market or in new adjacent geographies. And I think this is a legitimate way to increase the value of the target firm, although it may have negative consequences for consumers in that market because competition levels overall might decline in that market. So now let's come back to healthcare, and why is this a problem for healthcare? So first of all, healthcare, and I think there's no controversy over this, at least among economists, healthcare is not a well-functioning market as classically defined. So some of the classical aspects of well-functioning markets is that there is a high level of competition. Consumers are well informed. So, I mean, in the extreme, it's perfect information, but even if you forget perfect information, consumers are relatively well informed. And then the third one is that the price plays an important market clearing role, which is to say that the prices of products and services capture all the information that's necessary to clear the market, information about the quality of the product and service, and also information about demand and supply imbalances. If you see each of these three aspects, healthcare doesn't really meet the standard on any of these three. So in healthcare, we know that at least provider markets are highly non-competitive at a local level. This is very, very extreme in case of hospitals. Nursing home markets are more competitive, but even they do not really meet the standard for competition. Information asymmetry is a huge problem. Consumers are not as well informed about the quality of healthcare as providers are. Insurers and payers are not as well informed about the need for certain types of services as providers are. And so this creates to all kinds of problems, both in terms of selection as well as in terms of moral hazard. And in the extreme, a low quality provider can survive and even be successful in healthcare because consumers don't actually know. They can't tell the difference between two providers and quality of care. They can tell the difference in terms of the building and whether one building looks better than the other, and then whether one physician has nicer bedside manner than the other, but they can't necessarily tell the difference in terms of diagnostic quality and treatment plan quality. And then thirdly, price is completely disintermediated in healthcare markets. Consumers don't pay on the margin because they typically have insurance, which pays most of the price, and oftentimes prices are not transparent. Consumers cannot even see the price when they're making a choice about which provider to pick. So because of all of these issues, and then another issue with healthcare is that it's also difficult for payers to actually completely contract on quality. And the idea here is that payers do not observe quality of care. They do not actually know whether a nursing home is high quality or low quality. The only thing they can contract on is things like outcomes or complaints or other measures that they may develop through surveys or audits or things like that. And so there is this sort of balloon problem where, or a whack-a-mole problem where if a payer tries to tamp down on one aspect, you might have an imbalance on another aspect. And so they keep playing this game of whack-a-mole. And so this has led to an animated policy debate, whether we really want a very high octane for-profit structure like private equity in healthcare. And there has already been some controversy. There's been a lot of discussion already about surprise medical bills. Some of this is associated with private equity firms because they own, I think, almost 25 to 30% of all emergency room staffing companies in the US. And emergency room staffing companies were associated, or one group that was associated with surprise medical bills. There are any number of stories about how private equity firms acquire hospitals and nursing homes to facility-based providers and then sell the real estate. And there have also been some examples of bankruptcies. Here in Philly, where I'm based, the Hahnemann Hospital is a very famous example. But you also have examples in nursing homes. For example, the HCAR Manor Care deal, which was a very large chain which went bankrupt. Okay, so hopefully this has given you some background about what private equity model is and why their presence in healthcare may be an issue. I can stop here if there are any questions, but I'll take my cue from David. If you want me to proceed, I can also keep going.
I think since we got a little bit of a late start, why don't you keep going? And I would ask that if attendees have questions, Kathy, can they put it in chat or Q&A? Is that what the?
Okay, cool. I'll keep going, and yeah. I'll also speed up just so I want to make sure Ernie gets his time.
Yeah, thanks.
So in terms of what we know about the effects of private equity, the prior evidence is unfortunately still emerging. That it's still limited, and part of the problem is that data availability is an issue. A lot of the work specifically on nursing homes actually uses aggregate facility level data to look at the effects of patient outcomes, and so you lose some granularity and sort of the level of detail that you need to actually extract a signal on what happens to patients. And the evidence is mixed. Christine Harrington at UCSF and her co-authors, they've done a number of studies where they found some harmful effects on patients when private equity firms invest in nursing homes. But at the same time, there are other studies which have found no effects on patients. But with this caveat that the data that's been used has been facility level, either surveys or things like facility level staffing. There's been consistent findings that finances do seem to improve following private equity ownership. This Pradhan et al. Is a group of authors who've looked at nursing homes in Florida, and they found that their profitability tends to improve, their revenues tend to improve. Evidence in other segments of healthcare, for example, hospitals, is still emerging because it's a new phenomenon. I'll switch gears and talk a little bit about my own work. So we also looked at nursing homes. David alluded to this a little bit in the introduction. Private equity owns about 10% of all US facilities, and actually this number is now higher. This is from our data, which ended in 2016. We use administrative data from the Centers for Medicare and Medicaid Services, CMS. So we have the universe of Medicare claims, and we can also see all the patients from the minimum data set So this is a data set where they have surveys on every patient who's been admitted to a nursing home. Um, so we have about 15,000 facilities in our sample, out of which about 1,700 were bought. So for 50,000 facilities every year, and there's some entry and exit, so it's not a balanced panel, out of which about 1,700 facilities were bought by private equity firms in the period that we study. And we've sourced private equity deals from PitchBook and other sources. I won't belabor these issues, but obviously one issue or one concern that you may have is that private equity firms don't randomly pick which nursing homes they want to buy, and this is a very legitimate concern. So one thing that we do, which is very standard in the literature, is that we compare trends and outcomes at these targeted facilities before versus after they get acquired, relative to facilities that look like them on certain characteristics, but which were not acquired by private equity firms. So that's the idea. That's how this allows us to get rid of stable differences due to things like one is located in a certain type of market versus the other, or that perhaps private equity firms tend to go after larger nursing homes because they're only looking at differences in trends. So these stable differences get eliminated, and this is a very standard approach that's used in the literature. The other challenge, which I think is actually also important, and actually previous papers have not really focused on this aspect, and partly it is because they didn't have patient level data, is that when you think about what types of patients are going at these facilities, it's possible that once they are owned by a private equity firm, these nursing homes may shift their focus towards attracting certain types of patients who are healthier in some way and easier or cheaper to serve. And there are reasons to do this. Medicare payments. There's been some complaints and some analysis which suggests that Medicare payments for nursing home stays inadequately adjust payments for cognitive impairments. So Medicare payments tend to emphasize physical therapy and other kinds of therapy, and that's usually more appropriate for people who do not have cognitive impairments. But then for people who do have cognitive impairments, actually they're more costly to serve because they need more assistance, but Medicare payments don't adequately capture that. And then there's also this other piece of evidence that people have shown that nursing homes are very good at selecting what kind of patients they think will be more profitable for them, and so they may be cream skimming. So to deal with this issue, we take advantage of this well-known aspect of healthcare, which is that patients tend to prefer going to a provider that's located close to them, whether it's hospitals, nursing homes, emergency rooms, any kind of high-stakes treatment. Patients have a strong distance preference. And so we focus our analysis on patients that are likely to go to private equity-owned facilities because of a distance advantage. And so the underlying assumption here is that this aspect of patient behavior is not going to change before or after a nursing home gets bought out by a private equity-owned firm. These figures are making the point that we do see some declines in patient severity after a private equity-owned firm buys a nursing home. So on the x-axis, we have years from the year, years relative to the year of the deal. So negative years are years prior to the deal. Positive years are years following the deal. And the deal is, by deal, I mean when the private equity firm bought the nursing home. And then on the y-axis, for example, I'll just give one example. This is ADL scores, so activities of daily living. The higher the ADL score, the more impaired the patient is. And you can tell that prior to being acquired, ADL scores were, there seemed to be a slight uptake. So actually these nursing homes are getting sicker patients relative to the comparison group. But once it got bought out by the private equity firm, you could see that there's a sharp decline. There's actually a turnaround in the trend, and there's a sharp decline in ADL scores, which means that after the private equity firm bought the nursing home, the patients became healthier, at least on this measure. And you see similar sort of patterns on the others. But when you compare them by distance, actually the patients look fairly balanced. So this is, giving us some comfort that distance still seems to be randomly assigning individuals, because you may happen to be closer to a private equity or nursing home or further away, but that's not because of anything related to you. It's just happenstance. It's some combination of market factors. Okay, so in terms of results, I'll just show a couple of results. One thing that we find, so this figure is showing how far you were relative, how in terms of relative distance, how close or far were you to a private equity or nursing home. Negative relative distance means that you are relatively closer to a private equity or nursing home than any other type of nursing home. And positive distance means that you are relatively further away from a private equity or nursing home than any other type of nursing home. And on the y-axis, we are showing mortality rates. So we measure mortality at 90 days following discharge, but we find stable effects whether we look at 15 days, 30 days, or all the way to 90 days, even 1 year actually. And basically what this figure is showing is that people who are much closer to these private equity or nursing homes, they tend to have higher mortality rates following discharge as compared to individuals who are further away from private equity or nursing homes. We do the same exercise on spending. So here the y-axis is the total amount spent for the stay, and then also including the 90 days following the stay. Because these are Medicare patients, we can see their total spend. And you have a similar sort of pattern. Patients who are closer to nursing homes, they have higher spending than patients who are further away. And this is in spite of the fact that they tend to die sooner. So if you adjust for that, it's actually, this is actually an understated effect. So to summarize our results, we find that 90-day mortality increases by 2.4 percentage points. That's about 15% of the baseline mortality of these Medicare patients. At the same time, the amount billed to Medicare increases by about 10%. And if you include the 90 days following the discharge, it increases by about 8%. So basically, the amount spent increases 8 to 10%, depending on which one you prefer. And these effects are very stable and they're statistically significant across a number of sensitivity checks. We also find declines on other measures of well-being. So it's not isolated, only limited to mortality. We also find increase in antipsychotic drug use. We find an increase in pain intensity, a reduction in mobility. And then we also find for some placebo groups, we don't find any effects on patients. For example, patients who are treated at these facilities prior to private equity ownership, we don't find that their effects are any different than the comparison group.
So
Why
Dr.
is this happening?
So can I cut you at that point a little bit,
Yes.
Dr. Gupta, and switch over to Mr. Tosh for a little bit and then come back around as part of our discussion as to the mechanisms, if that's okay?
Yeah, absolutely.
Okay.
All right, let me get my mic on, share my screen here real quick. All right, hopefully everybody can see my screen. As I was introduced, I'm Ernie Tosh. I'm an attorney. I'm licensed in Texas and several other states, and my entire practice is nursing home abuse and neglect cases around the country. And when I was asked to speak with Dr. Gupta, I will tell you it's daunting to come in behind somebody that has the education that Dr. Gupta does when you're just an attorney from Texas. So when I saw his deck of slides, I was even more intimidated because really all I've got is pretty colors. I don't have the background research and statistics that he does, although I find that super fascinating. I love that stuff. So I could listen to him all day. What I want to talk about is more on an actual facility level, what we're seeing when these facilities file their annual cost reports. And the reason I want to focus on that is because the two things that I find that are most concerning right now with reporting problems in the nursing home sector revolve around lack of information on who actually owns a facility. And secondly, there is virtually no transparency on the finances of the nursing home. And the reason that that's important is because we need to know who owns the nursing homes to be able to figure out, is there a player in the market that is constricting competition? Are the individuals who are investing in the nursing homes through private equity or some other investing tool even supposed to be in this market? Because as we know, if you've been convicted of fraud, you're not supposed to invest in Medicare or Medicaid funded enterprises for at least a decade. So knowing who owns these nursing homes is very important. Also important is the finances, because we don't know without understanding the finances of these organizations whether they actually need additional government money. Now, they have been beating the drum for decades that every year we need more money, we need more money, we need more money. But we don't know if they actually do, because the financial filings are so deficient. And they're highly manipulated, and I'm going to show you how you do that. So before we go and give them more money, we should require them to report their income truthfully, so we can figure out if the taxpayer actually needs to give them more money or not. Or is this an occasion of a private equity group or some other type of investing group coming in and just profiteering and claiming they need more money? So let's look at nursing home finances. The thing that drives the non-transparency of nursing home finance is partially due to what are called related parties. It also limits the ownership transparency, as I'll show here. So this is the makeup of a traditional nursing home. Yes, ma'am.
This is Kathy. I'm sorry to interrupt. Is it possible for you to go to fuller screen with your slides?
I'm sorry, I can't. Unfortunately,
That's okay.
My monitor is really wide. And
okay. You don't have to explain that.
Yeah.
I apologize.
So,
go ahead. I'm sorry for the interruption.
Oh, sure, no problem. So the traditional organization within a nursing home company is that you have a parent company, in this case, Southern Mega Healthcare, and it owns multiple nursing homes, and it also owns like a real estate holding company, a management company. It may own therapy companies, pharmacies, etc. Pretty much anything that could provide supplies or support to a nursing home. Southern Mega may own a company that does that. And then it executes contracts between the nursing homes and these related parties. And they're called related parties because they share common ownership. In a family setting, it would be that they share a common parent. In this case, the parent, Southern Mega, and all the other companies are Southern Mega's children. Now, we want to look at the original income statement, and I made up a nursing home called Grapevine Nursing Center, and this is what its income statement looks like. There is total patient revenue of 16 million. They had to write off about $1.75 million for contractual allowances and debts they couldn't collect. And so they actually had patient revenue of $14.25 million. So that is actually what hit their bank account. Then they had operating expenses of 13 million. And so they showed a profit of $1.25 million for this year. And so you can see from this setup, from this report, they are very profitable. And if they were standing in front of you telling you they're about to go bankrupt and they need more money, you would call BS on that, because that is clearly not true. So we need to fix this income statement. because showing that much profit is a real problem. It's a problem because it makes you a target for litigation, because if you go and kill somebody with your neglect and a plaintiff's attorney comes in and sees you're super profitable and have lots of assets, you become a target. So also, again, you can't go beg for more money if you're showing a huge profit. So what you need to do is you need to go manipulate your operating expenses. So we go back to our model and we say, how do we manipulate Grapevine's expenses? Well, we do that by using a management company, a real estate company, therapy companies to do that. And so in this case, what we're going to do is we're going to fix the income statement using a real estate company. So again, here's our original, 13 million in operating expenses, $1.25 million profit. Within that original income statement, about 600,000 of that 13 million in expenses was attributed to real estate. They had about a $500,000 mortgage payment. They paid taxes of about $100,000 on the property. So of the 13 million, 600,000 was the cost of having the building. So what we do is we move the building over to a real estate holding company, and then we lease it back to the nursing home, but we don't lease it to them for 600,000. We lease it to them for 2 million. Okay, so now their expenses are much higher because we added a $1.4 million siphon. Okay, and what we're saying there is originally they had a $600,000 cost. Now they have a $2 million cost. The real estate company is siphoning $1.4 million out of the nursing home and into the real estate holding company. And then that will flow up to Mega, okay, to Southern Mega, because that's the parent. Now, when we look back at the original income statement, this is what it looked like. That $1.25 million profit was our problem. So this is how we fix it. We increase our expenses by the difference between the original 600,000 spent on real estate. Now it's 2 million. So that's a bump up of 1.4 million in expenses. So our expenses went from 13 million to 14.4 million. And look what it did to our income. We went from making 1.25 million in profit to losing 150,000. Now what have you got? Now you got a piece of paper you can wave around at the legislature and say, look, my facility loses money. I need more money. I need more reimbursement. What they're not showing you is the real estate holding company's profit or Southern Mega's profit. What they're doing is showing you a manipulated income statement. This also is good for litigation because now if an uninformed plaintiff's attorney arrives and has a case against this facility, they're going to think the facility loses money and they're going to have no assets because their assets, their biggest asset, real estate, is now held by a different company that they can't get to in the litigation. And so why sue if you have no chance to recover? So this is the actual filing that you will see if you go pull the federal annual cost report, which is called the 2540-10. That's what its formal name is. It has about 66 different worksheets of financial information. This is worksheet A81. And what it lists here is the services that are provided by related parties, how much the cost is for the service. A cost meaning what did it cost the related party to provide this service to the nursing home. The next column over, column 5, is basically how much did they pay for this service. And then the final column is, was there an overpayment or an underpayment compared to the cost? And what we can see here is that this particular nursing home paid $449,000 more to its related parties than the cost of the services they were providing. So what that means is they bumped their expenses up by nearly $500,000 so that they could decrease their apparent income. So what are the issues with cost reports? The issues are that they are not audited and certified by a CPA. They are signed by somebody within the company that says that they're accurate, but they are not audited or certified by a CPA, which means they may or may not be accurate because the person who's signing them is usually not the person who prepared them. In fact, I would say it's almost never. Secondly, they're not audited by CMS. Now, CMS will tell you they audit them, but they don't. The reason I know that is because I have the entire CMS cost report database dating back to 1996. I have every cost report that's ever been filed in the United States. And I can tell you by using that database, there is no possibility that anybody audited that stuff as it was coming into the database, because we have found time and time again cost reports that are inconceivable with the numbers that are on there. There is no way in this entire universe those numbers could be correct. And yet CMS put them into the database and they've been sitting there for years and years and years and were never corrected. So no, CMS doesn't audit this stuff. So you have an issue of garbage in from the nursing home means garbage out when we go try to do research or litigation with this information. There's no ownership transparency. Again, if you go look at CMS's ownership database, it is incomplete to say the least. We need better ownership transparency. I cannot go in there and figure out which facilities are related to each other using CMS's own ownership database. We can get a general idea of who might be in a specific chain, but which facilities are 100% in that chain? No, can't do that. I was trying to do that recently for the AG's office in New Jersey, and we finally had to give up using CMS's ownership database because it was too incomplete. And no financial transparency. As we discussed, they can manipulate their financial statements by using these related parties. It hides their assets. It also hides their income. And the way that I generally describe this to people is if you were presented the tip of an octopus's tentacle, just the last inch of it, and you were asked, what creature is this? Now, if it had a suction cup on it, you might guess that it's an octopus, but it could be a cuttlefish, it could be a squid. It's some type of cephalopod probably, but you don't really know for sure what creature that is. Well, that's what these cost reports are. They're the tip of the tentacle for the entire corporate structure. Southern Mega, when it files a cost report for Grapevine, it is showing you the tip, but you have no earthly idea what the rest of that creature looks like. And so, excuse me, so what we're asking for, what we're advocating is full transparency from Mega down, okay? That way we can understand how much money these facilities are making. how much money Mega is making. And is this a reimbursement problem, or is this an allocation or utilization problem that is a problem because the company is profiteering? Now, what effect does this non-transparency, especially in the financial area, have in the real world? Well, for Southern Mega, it's protecting their assets in shell corporations. It is siphoning money so they don't show profit. And these things lead to understaffing. Now you may ask yourself, why? Why would hiding assets in a related corporation increase understaffing? That doesn't really seem to be a correlation. Well, it is because when you protect assets in a shell corporation, there's no risk of losing those assets in litigation, which now creates a disincentive for you to behave correctly. If you know you can't be punished for your actions, you will not generally abide by the rules. So in this case, if you're not going to get hit for your continued negligence in treating your residents, if your downside is a few $1,000s for doing that instead of losing your building, why staff correctly? Siphoning money, as we've shown, decreases your profits. When you can hold up an income statement that says, I lost money, you can now reduce staffing. And when people complain that you're understaffed, you can pull out your little financial statement and say, oh, look, I didn't have the money to staff up. I couldn't add any more staffing. We were losing money. I actually had to cut staffing. Well, we know that's a lie in our context of this made up Grapevine Nursing Center, but that's actually how every facility that's basically a for-profit is run. Cut your staffing and you increase your profits dollar for dollar. It's the easiest expense to control, and it is immediately profitable. So siphoning money gives you a great excuse for not staffing appropriately. And again, why do you understaff? Because it increases the profitability of the company. And it will do that whether it's a PE invested company or if it's somebody else that's investing in this company. If you cut staffing, you will increase profitability. I want to do a real quick staffing analysis for you so you understand why understaffing is so profitable and why we see it so rampantly in the for-profit sector. The way you do a staffing analysis is you calculate expected staffing. That's based on the care needs of the residents. And if you're familiar with minimum data sets or MDSs, Dr. Gupta mentioned them briefly in his presentation. It's the assessment that is periodically done at the facility that sets their reimbursement level for Medicare and Medicaid. And within that document contains a lot of information about their healthcare needs. And so you can use that document to actually calculate how much staffing each resident needs. And that's called expected staffing. Then you look at the reported staffing. There is staffing reported to the federal government in the annual cost reports, reported to the state government in some states' Medicaid cost reports. Pennsylvania does require staffing to be reported in those documents. And also there's the payroll-based journal, which is daily staff reports from each facility, which are submitted to CMS. So you've got different places you can look for reported staffing, and then you figure out what's the difference between those two. So let's do this very quickly. Again, expected staffing, reported staffing, what's the difference? We break that down into RN, LPN, and AID components because that's how you calculate how much staffing they need. It's, your aides do a different task than your RNs, so you have to know which level of nurse or healthcare provider you need, and then how much time. Now, in this case, this facility had an average of 4.46 hours per patient per day that was needed in healthcare. So it was broken down, 1.23 hours of RN time, 0.65 of LPNs, and 2.58 hours of aides. So each resident in that facility will need slightly different numbers, but the average across the entire building, 4.46 hours. Then we go look at what did they actually staff at. And we pull from one of our available sources. Turns out they reported 3.57 hours broken down as we see here. Now, one thing I'd like to point out is if you look at their RN time, you will see that their reported RN time is way below their expected RN time, and that their LPN time is actually higher than their expected. This is classic for-profit staffing. Okay, we see this. If I see that trend in a facility, I don't really even have to go look to see if they're a for-profit or nonprofit, because that is for-profit staffing. Cut your RNs to the bone and then overstaff your LPNs a little bit to cover some of your RN shortage. Problem with this is LPNs can't do what RNs do. Okay, your scope of practice rules in every state set out specifically what they can do. And LPNs are not RNs. And your RNs are your most expensive labor. So if you can cut RNs, you can certainly increase your profitability. So when we take the difference between these two, we see that 0.88 hours loss of RNs. Now what this is that's per patient per day. So for the total of the day, they're down about 9/10 of an hour per patient. You go, well, that's less than an hour a day per patient. That doesn't seem like a huge deal, but it is. And I'm going to show you how you value that. You value that by multiplying their shortage or their overage by their average hourly wage for that nursing category. So in the federal cost reports on worksheet S-3- the Roman numeral 5, they actually list out what their average hourly wage is for RNs, LPNs, and CNAs in this facility. So this is not a state average or a national average. This is this facility. This is what it's worth to Grapevine Nursing Center to short their staffing. So when you multiply that out, you see that they're understaffing RNs by $29 a day per patient. They're overstaffing LPNs by about $8 a day, and aides they're shorting by almost $5 a day. So on the whole, they're understaffing by $25.74 per patient per day. And you go, yeah, big deal. That's a dinner, at a decent restaurant, one dinner. So what? Well, if you multiply that by 365 days, that is how much you save for each bed that is in this facility, or for each resident over a year, however you want to look at it. So it's almost $9,400. And if you have 105 residents in your facility, by staffing in this manner, you save just short of $1 million. That is why understaffing is so crazy profitable. So just to sum up my portion of this, there is no transparency. Private equity is hiding the money. Other types of investors are hiding the money, and the outcomes are horrible. And it's primarily horrible because of the lack of staffing. You use this corporate structure to do the manipulation, but right now we are just getting financial cost reports from Grapevine Nursing and from Memphis Nursing. As we talked about before, that's basically showing you the tip of the tentacle. We do not have a financial filing for the real estate holding company, the management company, or for Southern Mega Healthcare. Now, Southern Mega would have to file a home office cost report, but just to make sure you understand, all that is a statement of how much Southern Mega expenses were during a year and how they allocated those expenses down to the nursing homes. It is not a financial statement of Southern Mega's profitability or unprofitability. So when you look at this structure, the only information we're really getting is the tip of the tentacle. And as I demonstrated, that is manipulated, so it doesn't do us any good.
So this is great. This is great information. And so let's move to remedial actions in our last 20 minutes.
Okay, well, actually, that's exactly what I was fixing to say right now.
Okay.
So,
Okay.
Sorry about that. But yeah, the biggest questions we've got are who owns the parent company, and is poor care due to reimbursement issues or underutilization of the current money? How do we fix that? You have disclosures of owners that go all the way back to the investors so that we have 100% ownership transparency. The second thing you need is consolidated, audited financial statements from the parent corporation to the bottom of the corporate structure. And I am a huge advocate that the states need to implement both of these. CMS is, a giant bureaucracy, and I don't hold out much hope that CMS is going to fix these problems. And I firmly believe that the states are in a position to actually do this. And if you want to take a look at this, look at the state of Virginia. Virginia already did this. And so they've had it for a few years now. If you have a single facility in Virginia, you have to file consolidated financial statements from the parent corporation to the state of Virginia. So this is my contact information. If anybody wants to get hold of me, I'll be more than happy to answer any questions that anybody has.
So thanks again. So in moving to these remedies, we want to have questions from the audience, and any questions for either presenter at this point. But I would want to tee this off because it is a long time ago since I was in state government. How do we avoid having all this data? Because let's assume everyone agrees, the policymakers, the regulators say, yes, we want fully auditable, consolidated financial statements for a nursing home. We want it before you come into our state, into the Commonwealth of Pennsylvania, before you're licensed. We want to see your history on an annual basis. We want to get this information. Who is going to look at all this data, and what are they supposed to do with it?
Well, the number one, the ownership database is going to allow the state to check as the PEs or other investors are purchasing facilities to understand, are they getting monopoly in a certain location? So number one, your state health agency that licenses your nursing homes will have access to that to determine if they're going to approve the purchase in that location. Also, you want this information available to researchers like Dr. Gupta, who can go in and do an analysis to determine is this type of ownership or whatever question may arise at that point that involves ownership. It allows them to do relevant analysis. Also, to be 100% honest, it also helps in litigation, because when you're litigating against some of these mega corporations, if they have acted particularly bad, you get to what are called punitive damages. And when you get to punitive damages, the value of the corporation becomes an issue for the jury. And if we can't determine which facilities and companies are associated with each other, we can't give an accurate value to the jury to consider in their deliberating what appropriate punishment is.
Okay, and you know, Ernie, we lost your camera.
Yeah, I've been trying to turn it back on and it just won't turn on. I don't know what happened. I'm glad it failed instead of the mic.
No, it's great. And so, Atul, you talked about the different fees associated from private equity. You talked about sales leasebacks and dividend recapitalization and management fees and related party transactions and roll-ups. When you're looking at this data, how much, when does it become painfully obvious that all this money is being sucked out to the detriment of resident safety? You know, when does it go beyond reasonable? What standards should be applied if I'm a regulator or if I'm a policymaker, and say, okay, if they're providing value, they're entitled to management fees, or if they're providing value in some fashion, when does it overcome reasonableness to the detriment of patient safety?
Yeah, that's always a difficult question to answer. I think you can look at the two separately. I think, you know, as far as the state is concerned, or even CMS, you know, these regulators, they need to be able to track the quality of care at these institutions, and then they need to they need to track it all the way to the owner, which is why I completely agree with Ernie that you need transparency in ownership. If you look at the CMS database on ownership, you can only see some people who have ownership in that particular facility, but then you can't link to, you know, the PE firm might have different shell companies that own different nursing homes. So you can never really take it back all the way to the private equity firm. So you need that link to be established so you can hold the ultimate owner accountable. And then secondly, I think they need to change the way they pay these facilities. They need to link payments to quality. And I think once you make the feedback loop from quality, you know, bad quality leads to a reduction in payments. I think once you put that feedback loop in place, even firms that are profit oriented will take note. And then, you know, then they will be incentivized to improve their quality of care. So then I think you don't need to necessarily take a call on or a value judgment on, oh, how much money is too much for you to siphon out of the system. You know, because as long as they are meeting the bar on quality, you know, in some sense, you can be agnostic about whether they're making money or not making money from the nursing home.
Okay, great. And Ernie, to follow up on that, aren't there existing conflict of interest regulations or related party regulations that would prohibit your example with Southern Mega using services from all their own companies?
The answer is yes. There are regulations about that within CMS's publications. Very specifically, they are supposed to be what we in the legal profession call arm's length transactions. So when you look at them, they should appear as though a reasonably prudent buyer executed that contract. Now, even though that's the regulation, CMS doesn't enforce it. There, you go into a company, you know, like Southern Mega here, who has inflated the rent to the nursing home. They have not done any study within the geographical area to figure out what the per cost value of a nursing home or relate, you know, something similar to a nursing home, what the per value rent is for that, and then tried to adjust their rent for it. They don't do that. They don't do that for any of the services provided by the related parties. How do I know that? Because I do these depositions all the time, and they don't do that. They are not reasonably prudent buyers. In fact, it is not uncommon for us to get a contract for a lease or a therapy company that is signed for the leasing company by David Hoffman, and it's signed for the nursing home also by David Hoffman. So how did David Hoffman negotiate in good faith with himself? That's
Well,
not
I'm very reasonable, Ernie.
Well,
I'm an ordinary reasonable guy, but it's a great point. But so there's no enforcement.
there's no enforcement. Exactly. The regulation is there and there's no enforcement.
And there's talk in the Nursing Home Improvement and Accountability Act of 2021, which is being proposed out there to enhance this idea of cost reporting and oversight, and funding, I believe, is one of the components to really have people, look at this more closely. One of the questions that we've received was, is there evidence related to staffing, turnover, pay rates of nurses and CNAs in regards to private equity versus nonprofits?
So, one thing I can say is that in our work, we did find a reduction in CNAs. In fact, the largest reduction in across the 3 different nurse types was actually in nursing aides. But we were not able to look at their salaries because as Ernie mentioned, the cost report data is super noisy and not quite reliable. But in terms of the hours per patient day, there was a dramatic reduction.
Yeah, and to follow up on the staffing issue, as Ernie pointed out, with the playbook to cut RNs because it's a greater cost center, that does impact your 5-star rating. So ironically, RNs are double counted in the RN in the 5-star rating, and as a result, you show less RN numbers. Then you may save money, but then your 5-star ratings are in fact going down. And I totally agree with the increase of LPNs will not suffice in actually on the care delivery side, and then again puts residents at risk. And so a lot of this is just misaligned in terms of an approach. We also received another question in the chat, in the Q&A session. What should PA's new regulations require to protect residents from PEs milking the facility at the cost of quality, and to keep nursing facilities from claiming the need for Medicaid increases when it is not needed? Transparency may not be enough. I'll open that up to both of you.
Well, I would agree with Dr. Gupta when he said that the way you protect the residents is to be monitoring quality and reimbursing on quality care. Don't reimburse just because they show you a financial statement and claim they're about to go bankrupt. Force them to provide good care up front and reimburse those that provide good care. If you also have transparency, that's going to show you the business model that's going to be able to deliver an adequate profit to have people stay invested in the sector, but at the same time provide the best quality for the residents. And David, just briefly detouring back to your comment about cutting RNs hurts your 5-star rating, that's actually not true. And I'll tell you why. You would think it's true. It makes sense that it would be true. But the problem is the 5-star rating system is a comparison of one building to another on how much they staff in that area or that state. So if you are in an area that is mostly for-profit nursing homes, you are comparing, does this for-profit nursing home staff better or worse on RNs than this other for-profit nursing home? And they're both massively understaffed. So you say, oh, no, they're pretty much average. They're a 3 or 4-star because they do what everybody else does. That's how the 5-star system is set up, which actually breaks it because it was actually functioning better in prior to April 1st, 2018, when they changed it to be this, how does the facility staff compare to other facilities in the area? The better measure is the facility staffing to the acuity needs of its residents? Okay, well, how is it doing versus expected staffing? And that's how they used to measure 5-star.
Well, and I went back to the original methodology of the 5-star, and if you looked at the numbers that went in, it was RN plus RN. It double counted them. But
Yes. No, you're absolutely right.
Yeah,
It's
so,
just that when you measure, one bad facility against a pool of other bad facilities, you're going to get a 3 or 4-star, even though you don't come close to meeting the RN load that you have. It's just, it's a broken metric.
all right, thanks. We have a question from Tom Holroyd. Is there a way to, Tom?
Yes, can you hear me?
Yep.
All right. Well, thank you all for putting this together. If I could return to the question about enforcement, the arm's length issue, and transparency. I think that the transparency would certainly help expose some of these things, and requiring the reporting at the state level is certainly going to be a benefit. But if there are existing CMS requirements here, is the state going to be in a position to enforce anything, or are they just in a position to expose it? Are we still going to be relying upon a lackadaisical federal government who has partial information in the ownership database, but isn't looking at anything to begin with? Are we, we'll take one step forward, but how many steps are we going to be behind getting to where we need to be for enforcement? Does that make sense?
Yeah, no, it makes perfect sense. Dr. Gupta, it looks like you were about to say something. I'll let you go.
I was only going to say that I think states can go beyond CMS, right? Like in terms of what they require. Ernie gave the example of Virginia, which has, it seems like it has a higher bar for what kind of ownership information needs to be submitted. And I would advocate that, this information should be submitted to the state. And even if they don't necessarily have somebody checking it, they should just make it completely public so that researchers like me, or even patients and advocates like Carrie, they can do some analysis of this. And I think that just raises the general bar of good behavior that's expected from these firms, right? They know that this information is out there and they can be held accountable. And just to take a step back, actually, David, to your earlier question, I think we need 3 things. And I think we don't want a solution that's private equity specific. I think we want a solution that just generally encourages good behavior and holds bad actors accountable. Because today they're called private equity, tomorrow they might be called something else, right? And so I think there's transparency that Ernie's already mentioned. I think we need an alignment of financial incentives, which I spoke about earlier. And I think that includes doing something about addressing the disparity